I'm pleased to present here the REALIGN study, which is the first study testing one of the novel anticoagulants in patients with a mechanical heart valve. This was a study, a phase 2 study, designed to test a new dosing regime of Dabigatran in patients with a mechanical valve. So this was not a clinical endpoint trial. These are my declarations of interest. So what is the background? We know that vitamin K antagonists, the coumarins, are effective and protect against thromboembolic events in patients with a mechanical valve, but we all know the disadvantages of these agents, food, alcohol, drug interactions, and the need for monitoring, taking blood samples every 3 to 4 weeks, lifelong, to test the level of anticoagulation. We also know from the REALIGN study performed in non-valvular atrial fibrillation that Dabigatran 150 milligram is superior to Warfarin in this indication. And there are encouraging preclinical data, in fact in pig models with a mechanical valve, that Dabigatran is also effective in these models. I don't have time to show the data on these animal studies. This was the design of the REALIGN study. So there are two populations. A population A, these are patients who got a recent surgery. So during the index hospitalization, either a bileaflet aortic or mitral valve, or both. And then there is a population B. These are patients who got a mitral valve bileaflet more than 3 months before randomization. Randomization was 2-to-1, 2 Dabigatran, 1 Warfarin, and the dose of Dabigatran was adjusted according to renal function. And adjustments of the dose was possible based on the hemoclot, on the level of, in fact, a reflection of the concentration of Dabigatran. As you can see, up to 2 times 300 milligram BID was given to patients with a very good renal function. All patients had to take study medication for at least 12 weeks, but were invited to continue the study medication afterwards. So the trial was designed to test this dosing algorithm in about 400 patients, but because of clinical outcomes, which are shown on this slide, the DSMB recommended to stop the trial, and the reason was an excess of thrombotic events, and also, which I will show on the next slide, an excess of bleeding complications. Look here, the most important one are in red: stroke, 9 strokes with Dabigatran in population A, 0 in Warfarin, population B, no strokes, overall 9 against 0. TIA, systemic embolism, we didn't observe. MI, we know that 2 of the 3 cases observed with MI, there was evidence of thrombus on the valve. There were also cases with thrombus on the valve without clinical data, without clinical symptoms. So there were 3 patients here in population B, so who got surgery more than 3 months before the randomization, who had evidence of valve thrombosis without symptoms. And if you look at the overall combined endpoint of thromboembolic events, at the bottom of the slide, you have 12 cases against 4, and with population B, 3 against 0. Overall, there was clearly an excess of thrombotic events. If you look at the safety data, I mean by that the bleeding data, you see more major bleeds in the population A. This was not the case in population B, and it's remarkable that all the patients with a major bleed had a pericardial bleed during the index hospitalization. If you look at any bleeding, you have 35 cases against 8 in population A, 10 against 2 in population B. So overall, this was clearly negative: more thrombotic events, more bleeding complications, in spite of adjusting the dose of Dabigatran based on renal function. What are the possible explanations for this negative study? Well, possibly inadequate blood levels of Dabigatran. But you can ask the question, yeah, would you increase or decrease the dose, because we had both thrombotic events and bleeding complications. Could the play of chance be an explanation, because indeed there were few events seen in the Warfarin arm? Or, and that's what we believe to be the most important or most likely explanation, differences in the mechanism of action of Dabigatran compared to Warfarin, and more specifically, the inability of Dabigatran to suppress activation of the coagulation that occurs when blood is exposed to the artificial surface of the prosthetic valve. And this is a bit illustrated on this slide. You have the contact thrombosis pathway, you have the injury, the tissue factor pathway, the common factor, the common pathway of coagulation. And you see that Dabigatran is only working on thrombin activity, and Warfarin has also an effect via factor 9 on the contact thrombosis pathway. It has also an effect on tissue factor, on factor 10A, and on thrombin. So if this hypothesis is true, then this is also valid for all the anti-10A agents. And the conclusions of this small study, negative study, is that these agents must not be prescribed to patients with a mechanical valve. The study is online as of this morning, accompanied in the New England and accompanied by an editorial. Thank you.
Frans, thank you very much. So it's really important that studies tell us both what we should do and what we should not do.
Absolutely.
And I think this has been a very important presentation. Questions?
Mitchell Zola, Cardiology News. So I want to clarify what you were saying at the end, that you think that the warning message of this trial may also apply to factor 10 inhibitors?
It's not tested, of course, in this study, but most likely this is also valid. And since it has not been studied, it would not be wise, if you are a cardiologist, to prescribe these agents to a patient with a mechanical valve.
Now, Frans, one of the things you emphasized in the atrial fibrillation studies is this is non-valvular atrial fibrillation. But please clarify that a significant proportion of the patients had disorders of their endogenous valves. For example, some aortic stenosis, some mitral regurgitation.
That's correct, Keith. But there is no foreign body in the heart.
There's no foreign body. That's the critical thing. Yeah.
So can I ask you another question? But can you speculate more on the mechanism? Because I do understand that, for instance, this agent does not inhibit contact activation. But
yeah.
How come the bleedings are higher?
Well, first of all,
mechanism?
Well, we give relatively high doses of Dabigatran. Dabigatran is associated with a bleeding risk, as also observed in the real-life study. Fewer bleeds than with Warfarin. But since we adjusted the dose to have a minimum trough level of 50 nanogram per ml, we had to increase the dose up to 300 milligram BID, and that was associated with a bleeding risk, especially in the population who got recent surgery. Mm-hmm. And so the investigators were asked to start the study medication 3 to 7 days after surgery. And so, in spite of the fact that it was not immediately after surgery, there were still pericardial bleeds, because the action of Dabigatran is much faster than with Warfarin.
Yeah. Thank you.
There was a question over there.
Yes, Serge was native from France. Of course, you didn't test it, but have you any recommendation following Realign and regarding biological valve? Which is a very important concern in daily practice.
That's a difficult question, but most cardiologists agree that you don't have to give oral anticoagulation in patients with a prosthetic valve. In the initial, at least not after a couple of months. Some cardiologists...
Biological valve.
Biological valve.
Yes, but in case of AFib.
In principle, but again, this was not being tested in this study, you should or could prescribe these novel agents in patients with a biological valve in atrial fibrillation. because there is no need for, if it is a sinus rhythm, there is no need to give an anticoagulant. So then you give it only for the fibrillation and not because there is a biological valve in the heart.
Harry?
Just to add to the comment about this is true for thrombin inhibitors, whether it's true for 10A inhibitors, we still need to find out. The mechanism of that is very, very different. One molecule of factor 10A generates about 1,000 thrombin molecules. And so inhibiting at the level of 10A might actually be effective. What you see here, as you explained, Frans, is really you have the whole coagulation cascade go, and it needs to be inhibited at the really last stage when you have millions and millions of molecules of thrombin. And that probably is quite difficult. If you do it higher up in the cascade, it might work.
Would you take the risk to test it in patients with a mechanical valve?
I know there are people taking that risk, yes.
With a bioprosthetic, it's with a bio.
So, Harry, would you take it yourself?
You know, I love study, so I would study it.
Yes, he jumps off the fence as to whether he'd take it himself. Right. So, Frans, very important study. Thank you very much. I think we need to move on.
Yeah. So we move on to Roxana Miran. Who's going to tell us a little.